We'll give it a couple of minutes to let people join in on this beautiful Friday morning. We're excited to welcome you all to our today's webinar. If everyone could, for the moment, mute themselves as the panelists, as I'm welcoming everyone and introducing this event. So, good morning. My name is Maria Music. I'm a associate professor at Michigan Medicine, Department of Psychiatry and OBGYN. And I am also the co-director of Zero to Thrive and the medical director of MC3 Perinatal, the two programs that are sponsoring today's event. Just briefly to update you what Zero to Thrive and MC3 Perinatal do. Zero to Thrive is a program within Michigan Medicine that is dedicated to improve the wellness and resilience of pregnant, postpartum persons, their families, and young children, and to promote this through clinical work, direct service, policy, program development, research, and education. MC3 Perinatal is a Michigan state-wide perinatal psychiatry access program that promotes perinatal mental health knowledge and support to providers in primary care, OB, family medicine, pediatrics, to really support families with young children in the perinatal period, pregnancy through postpartum, and then also again into the child's early years. So we are very excited that these two programs, together with Michigan Medicine Psychiatry, was able to sponsor this event today, and we are really in for a treat. So I will turn it over to the moderator of this event, Dr. Angela Johnson, who is also faculty in Zero to Thrive. She is our director for diversity and inclusion, and is also by training a sociologist and an expert in breastfeeding, has published multiple really outstanding papers. So without further ado, welcome everyone for participating today. And Angela, it's your turn to lead us through this event, introduce the speakers, and moderate this phenomenal event. Want to also highlight one more person, Smita Bhattacharya, apology. She is the program coordinator for MC3 Perinatal, and she has been instrumental in putting on this event today. So thank you so much, everyone, for being here today. Angela?
Yeah, thank you, Maria. Thank you, Maria. Good morning, everyone. Welcome to this exciting event, the kicking off Friday. I consider this an early kickoff to what I hope to be a wonderful weekend for you all. Again, thank you so much for joining. I think we have an incredible lineup today of expert panelists who are going to provide you great information and an insight. So for this reason, I'm so excited to be here and have this opportunity to dialogue and to discuss perinatal health in the context of breastfeeding, and all of the essential ways that we can support as a community in our respective areas. So alongside esteemed colleagues, again, who are experts, what I want to do is walk us through a little bit of what we can expect today. Next slide, please. Thank you, Smita, for moving the slides. So the goals for our session today are pretty straightforward. We're going to start off by sort of covering a little bit of information that reflects or sort of demonstrates to you the variance that exists in the social, the cultural, and the societal conditions that contextualize maternal health experience. And that, of course, would contextualize those experiences and those outcomes for breastfeeding among mothers. And We're also going to describe, our wonderful panelists will describe some effective support techniques, strategies that we can employ and that they employ to help support mother's breastfeeding interest and her other perinatal needs. Maria's talked a little bit about, our wonderful panel of experts. Experts hail from pediatrics, Dr. Lisa Hammer, and public health. Lens and perspective is well entrenched into what we're going to share today. We'll also have lots of expertise, of course, from lactation experts. We have all of our panelists have some hand in lactation support and are experts in the field. We also will speak a bit in terms of the maternal mental health perspective. We're hoping to share information that will help guide your understanding and your own practice. We'll be providing some potential strategies that we think will help foster positive maternal mental health, as well as breastfeeding behavior. We know that breastfeeding behavior is an optimal maternal health behavior when it can be achieved. And then sort of in sum, what we hope to do is to provide you with this collective, comprehensive, multidisciplinary perspective across all of our panelists. Next slide, please. So just a quick review of the agenda so you know what to expect. And of course, we'll be looking forward to you engaging with us, engaging with our panelists by sharing some questions and ideas. We'll start with this brief overview and introduction that I'll provide, and it sort of paints in the backstory. It contextualizes some of the ideas that will be shared by panelists. Our panelists will each present for about 20 minutes each, sharing their own view, their own expertise, and providing you some valuable information that I'm sure that you will make great use of. We'll have a break. All of us know that with the advent of the pandemic and the shutdown, we're all doing our best to work remotely. The Zoom fatigue is real. So we want to give you grace and give ourselves grace. And I think we're planning maybe a 10-15 minute break midway to stretch, take your quick potty break, whatever it is you need to do to refresh. And then we'll come back post break to start to give panelists an opportunity to engage with you directly through the question and answer period. We ask that you will please, throughout the webinar, place your questions in the chat box. If you have questions, if you have concerns, let us know, for instance, if there are technical difficulties that you think we should be aware of, but we will ask that you will place your questions into the chat box, and we'll do our very best to get to all of them, within the time constraints that we have today. I think we'll go almost a couple of hours. So after question and answer period, we'll just have a very brief closing period. I'll provide some sort of conclusive thoughts based on the discussion and based on the question and answer period that I hope will allow us all a takeaway of ideas, of sparks, of motivations that propel us in the direction of providing the very best care that we possibly can, the best care that we can around supporting breastfeeding and mothers. So, I think we're ready to move on. Next slide. So just really quickly, Maria shared briefly, I'm a sociologist by training. I also have some undergraduate preparation in psychology. So that's in some instances, I consider myself as sort of the, sociological and psychological perspective. I hail from this perspective that, societal conditions and structural conditions matter. So all of us here would then understand, I think you would agree, that mothers are the foundation of society. Right? The health of all of our society really depends on how healthy our moms are and how well we support them, of course, in that context, and then how able mothers are to provide and maintain care for young developing children. Not only are mothers the caregivers, is this sort of we've begun to understand from this very socialized perspective, caregivers in society, they're often also breadwinners for families. They are known to be the gatekeepers of family health. So mothers play a very critical role in our society. It's they're the bedrock of our societal functions. Without moms, I don't know where we would be. Mothers, the functions that mothers provide shape societal systems. They shape health behaviors for all of us, as well as those health outcomes. And in turn, societal systems shape those opportunities and those life chances that mothers experience. Um, so the fact that mothers are critical and they play this very foundational or critical role in societal health means that supporting them is critical for our societal health. But we know that despite our best intentions, that there are long-standing barriers and challenges to providing this support. There are long-standing historical injustices, structural patterns that have developed over time and shape our lived experience every day of our lives, make and create the barriers and challenges that mothers, as well as all of us, experience. Um, we know that there are unequal institutional and structural conditions, that there are the sometimes inequitable distribution of resources, vital resources that take place, and that the differences in treatment across social institutions will and do promote differences in maternal health outcomes. Next slide, please. So the history of breastfeeding behavior in US society is very interesting. We know that, several decades ago, there was this uptick in increase in breastfeeding behavior, breastfeeding rates across society. And that took place for various reasons. But let's visit the fact first that breastfeeding has very positive effects for mothers and children. And breastfeeding is foundational in its own way, based on the fact that it provides nutritional value, that it provides very vital and critical physiological support for moms and babies, and that it also provides developmental support, that babies benefit from the ability to breastfeed, and mothers also benefit from that ability physiologically and psychologically, and as well as nutritionally. The increase in breastfeeding rates happen, right? The good news is that there was this kind of societal wide overall increase in breastfeeding rates. The increased systems and policy supports had something to do with it. There was definitely pushback in terms of the formula companies offering the sort of milk substitutes that really had prevailed for a long time, for several decades in this country. Pushback from public outcry, and all of this together worked to result in higher breastfeeding rates. Health, economics, employment, and welfare policies and practice in turn also bolster the systemic support that mothers experience, right? That mothers experience, and that really help provide them the ability to breastfeed. We've heard a little bit about the Baby Friendly Hospital Initiative, and that was developed in 1991 by the World Health Organization and UNICEF. The Baby Friendly Hospital Initiative, I'll say a little bit more about it in a moment, was one of multiple policies that were created and are credited, or sort of credited for the increased breastfeeding behavior in this country. Although breastfeeding rates have increased over decades' time in our country, there still remain, unfortunately, significant racial gaps. We know that, unfortunately, it's persistent, and historically, Black and African American women still initiate and maintain breastfeeding at lowest rates. And this is a persistent gap. This has very much historical ties and very much strongly tied to the differences in systemic support that avails itself and that does not provide adequate support to African-American mothers. Next slide, please. So this is just a quick overview of what Baby-Friendly Hospital Initiative entails. Baby-Friendly Hospital Initiative really sort of provides this 10 steps process, and these are recommendations issued, endorsed, and promoted by several major U.S. maternal and child health authorities in this country. I think what's most important to sort of remember is this is sort of the intent to provide very systemic and structural support for promoting breastfeeding. These 10 steps were developed by a team of global experts, and they are said to be this sort of consistent and evidence-based practice that is believed to provide demonstrated increase in breastfeeding initiation and duration. This is the guidebook. Not all hospitals are breastfeeding friendly. And I know, for instance, in our own area, we cannot all attest to being breastfeeding friendly, at least in terms of the official designation. Next slide, please. So this is, really just a quick glance at the specific steps themselves, just to give you an idea of how systemic support might look with the assumptions that it could be successful. Hospitals that sign on and are officially designated as breastfeeding friendly institutions must, for instance, follow a written breastfeeding policy that's routinely communicated. There's the training of all healthcare and staff, informing pregnant women about benefits and management, helping mothers initiate breastfeeding. So they're really just a series of steps that institutions must follow consistently to really maintain the breastfeeding friendly hospital designation, giving infants no food or drink, the practicing of rooming in, encouraging breastfeeding on demand. This process really pushes healthcare facilities to closely examine, and it challenges, and it modifies these kind of long-standing policies and procedures, in some cases deeply held views. What is clear based on the literature is this process is really not an easy one to follow. It's not an easy process. Many institutions have adopted it, but there are still many places that are not breastfeeding friendly hospital designees. So we know to date that about 600 hospitals have been certified baby friendly, and that accounts for approximately, as of 2019, 30% of all births. So the experts agree that the goals of promoting breastfeeding are very noble. These are very lofty goals. And for those institutions that are able to follow and indoctrinate, then this certainly does prove to be something that's very, how shall we say, again, lofty. So the Breast is Best campaigns taking place alongside policy structures do underlie increased breastfeeding behavior. There is certainly credible recent research that supports. So next slide, please. But where we really have to begin to ask ourselves in terms of policy and breastfeeding practice, and knowing for those of you who and the audience do have a role and a function in providing support and experience and working with mothers around breastfeeding, can we really say, that breastfeeding is mind over matter? Is it truly pure intent? So I took this quote from an interesting article that I recently read, sort of discussing the backstory to breastfeeding versus bottle feeding. And Dr. Gallup makes this point that the decision to bottle feed can be made by design, for example, out of concern for the effect on the mother's figure, embarrassment about breastfeeding in public. time constraints due to employment, or by default. So this idea that, by default, physical inability to breastfeed, or where the mother produces inadequate breast milk, that those would be the determining factors in terms of whether she bottle feeds or not. But as one of our panelists will say, adequately describes so well, I'm sort of borrowing her perfect quote, that breastfeeding is not just about interest and intent, best intentions, that it often is well entrenched in the contextualized experience that moms and families experience. As a structural sociologist, I really ascribe to the notion that the lived experience, the life chances that mothers experience are really shaped and dictated by what she experiences in society, her experiences and her interactions with all of the social institutions. So that discussions about breastfeeding policies sometimes make these very assertive approaches to promoting breastfeeding. And they fuel quite a bit of firestorm of controversy. And they're reflective of the varying social and personal circumstances, I think, that mothers and babies exist in. What we must do, all of us as practitioners, as researchers, as clinicians, is to really consider the ways that we have to tailor care and support mother by mother, case by case scenario with this prevailing goal that breastfeeding is a priority. Of course, it is a priority alongside mother's preference. Mother's voice is really the most important, as alongside the safety and well-being. But that we should first broadly think about the world that mothers exist within, and that drastically impacts the way that she's able to, with all of the changing social landscapes, that these landscapes impact the ways that mothers can move and negotiate their space and their behavior in society. Next slide, please. So for instance, that we know in terms of social institutions that moms and families interact with and that shape health outcomes, least of them being, more important of them being for our purposes, breastfeeding, that workplace policies, the workplace, the employment, the paid work environment plays a tremendous role. So, breastfeeding alongside other maternal health behaviors are facilitated or negated by the complexity of factors, including workplace, paid work. It's simply not a matter of mother's interest. Many mothers return to work, and not only do they return to work, about more than 70% of mothers return to work, many of them return to work quickly. The rates are the time spent prior to return to paid work varies for mothers, but we can see from the literature, it could be as soon as 2 weeks. I think the average return to work period, to this period of time that mother is home with baby post-birth, is around 4 weeks. We all know about the Family and Medical Leave Act, established in 1993, which entitles new parents to up to 12 weeks of leave, right? Sort of protected leave, but we know that leave is unpaid. And it also depends on the parent being able then to afford to be able to take that unpaid leave. Estimates are that only about 60% of the workforce is covered. That FMLA is only provided in certain contexts. For instance, employers who have 50 or more workers are required to follow, other employers are not. And there are other circumstances that will leave many mothers uncovered by FMLA. When mothers do return to work, there are often inflexible workplace and employment conditions. There are current policy limitations that offer inadequate protections. And the US is only one of 3 countries in the world that does not offer the statutory paid maternity leave. So their estimates are about 70% of all US workers have access to paid leave. And that's moms and dads, that's everyone. Which leaves about 89% to have access to unpaid leave. And again, so we can think about it within the context of who is able to afford an unpaid leave. That in turn would dictate how quickly mom after birth returns to work. And there's a recent article. I was looking at the these statistics from the Bureau of Labor Statistics. And what became clearly evident is that for many women, maternity leave is just unaffordable luxury. Took that quote from a recent magazine article.
And my apology that I'm interrupting, but Angela, can I just briefly say there is a lot of background noise. I don't know whether there is something going on like paper shuffling, or if you are moving something. Could you just make sure? I think that we're getting some feedback from folks.
Okay.
Thank you. Apology.
I do have some paper here, so it might be. So a few notes. I didn't want to forget any important points. I'll try to mute that a little bit so you all can hear my voice better than the paper. But I do have a few additional notes I thought of this morning. I really wanted to share. Thanks, Maria. I hope that all others are on mute. Is that correct? Someone said
yes, that's correct, Angela. It's
Oh,
always the speaker only. So whoever the speaker is, please, I understand. I totally have that to my notes, but kind of move them carefully. Thank you.
Okay, could be me. Okay, thank you. And then at any time, if any of you cannot hear me, please pop. I'll try to pay attention to Smita. If I can ask assistance with, keeping an eye on the chat box. Please, I appreciate that feedback. I will try to keep the paper. Next slide, please. So, when we're thinking about the context of the societal context of what facilitates and what serves as a barrier to breastfeeding and to what enables or disables mothers' ability to experience breastfeeding with babies, we can think, for example, of, our most recent phenomenon of the COVID, the pandemic, which impacted had devastating impact on many of our lives. There are, certainly one of the biggest impacts, negative impacts, was this economic cost through paid work that many mothers experience devastating impact on their sort of paid work circumstances. Estimates are that about 10 million people were not working, and accounted for about 1/3 of all mothers living with school-age children in the US. Moms were hit hardest in terms of paid work relative to dads, that at least in those initial stages of the pandemic shutdown, according to the US Census Bureau. So at the onset of the pandemic, the share of mothers actively working to decrease more than fathers. And this is according to the US Census Bureau data. Mothers' ability to work, or her work paid employment rates declined about just over 20%, while the share of dads who were working declined around about 14% in April of 2020. So it's been about a year compared to, the previous month. So what's the biggest impact of this, right? The differences in active work status of parents. What kind of impacts did this have economically? These were certainly great impacts. And the two most cited reasons that mothers are more impacted by the pandemic is, one, that mothers are more likely to work in the service industry. We know that, in the US, manufacturing certainly declined in the years of several decades. That service industry is one of the largest and the most prevailing, and then that women often disproportionately occupy positions or functions within the service industry. And so these work and service industry and other jobs were heavily impacted by pandemic closures. We know about the shutdown of many businesses, restaurants, and places that serve the public. So this is especially true for women of color, who are disproportionately represented in low-wage service industries. And mothers of color and mothers in general carry this heavier burden than on average with having this negative impact. As well, women and mothers in particular, on average, are often having unpaid domestic household chores. Although there are many women occupying paid employment spaces, they still serve as primary caregiver of the family. And so household chores, childcare during the pandemic, especially fell on the shoulders of women during the pandemic. And this sort of draws everyone into this idea that all of us having to sort of retreat into our homes meant that the distribution of domestic labor was disproportionately on the shoulders of women. And it really disrupts a parent's ability to, in turn, sort of in cyclical fashion, actively work for pay now within the confines of our home due to the pandemic. So next slide, please. And of course, now that paints this idea that mothers perform double duty. About 60% of working parents have, no outside help in caring for and educating their children. This is data collected during the pandemic. So parents were at some point during the pandemic spending an additional time during the week on household chores, childcare, education, now helping children remote learn, in addition to maintaining the work if she was fortunate to maintain paid work. So women were spending more hours than men on domestic labor, and close to half of people who responded to this survey, the COVID-19 caregiver survey, reported that they felt that their performance at work suffered as a result. So overall, mothers across all race and ethnic groups did face challenges in the labor market as a result of COVID. Yes, and job loss was also another negative reality for many families. They're calling it sort of one of the casualties of COVID, in addition to the unfortunate extremes in death and disease and destruction. There was the casualty of job loss, the economic devastation. Working mothers either willingly had to leave jobs, or they were being forced out in extraordinary numbers. Many women left lower paying jobs in retail or service industries that only some were able to re-enter after the economy is sort of beginning to rebound now. And many others in professional education and health jobs have also left the labor force. So this graphic sort of illustrates the percent of mothers who have school-age children who left the labor force in the past year, and distributed by occupation type. For many of mothers, leaving even temporarily for childbirth or during the pandemic to care for children reduced their earnings, right? But it also reduced their potential for future career goals, future career opportunities. Next slide, please. So then what we began to see, and we for time's sake, I can only cover sort of this institution of workplace. We can start to imagine, though, this full cultural context of what breastfeeding support looks like or doesn't look like for women. Women not only interact in workplace environments, but there's the experience or the interactions with healthcare institutions and educational institutions. The societal support in the US for breastfeeding, therefore, has been variable, and it's rife with contradictions. Unfortunately, we're hearing more in social media and the public media now. There is more sort of public displays of the lack of respectful, responsive healthcare support. And this at times does discourage breastfeeding. And this is historical, that the current systems in place that are meant to, sort of make up our societal structures are often disjointed and inconsistent, and they overlook mothers' needs. And this has been especially true for Black and African-American women. Next slide, please. So specifically for Black and African American women, we know that breastfeeding rates, initiation and maintenance rates still lag behind, despite overall uptick in the increase in breastfeeding rates for all mothers. Um, the historical injustices associated with breastfeeding in the Black community have left this kind of indelible negative mark on a collective consciousness. All that has happened, um, starting with slavery, but certainly continuing with some of the civil injustices that mark different periods across our history, really have had their long-lasting impact on breastfeeding. So in addition to the way that societal institutions, including the workplace, healthcare, etc., impact mothers, there's also the social historical context that uniquely shapes Black and African American women's healthcare experience. Pre-colonial period, slavery, forced sterilizations at a period in history, and unfortunately often the current maltreatment of birthing Black mothers and their families. So this graphic is a model that we adapted. This is a social ecological perspective or framework that we adapted to really demonstrate the psychosocial factors that influence breastfeeding for, in this case, uniquely African American mothers. But I think we can really say that some of these factors are true for other women as well. So that, for instance, the individual factors that really predict and determine the ability to breastfeed include mental health status for mothers at the individual level, attitude, knowledge, beliefs. And we can take that throughout the ecological system and look at the interpersonal level, her family, friends, peers, how well they facilitate or negate breastfeeding. The institutional level, we've talked a little bit about workplace, but there's also hospital policy. We spoke a little bit about healthcare providers, lactation consult, the accessibility and availability and quality to that lactation support. Policy and macro systems really matter. We've spoken a little bit about the baby-friendly hospital initiative. And then last, and but certainly not least, that last outer rim, and that's the adaptation, that the social historical context has predicted the ability to breastfeed uniquely for African American women based on historical context of their lived experience. Next slide, please. So, really quickly, again, we know that Black women uniquely are disadvantaged. Disproportionately, they're more likely to suffer from chronic psychosocial stress and depression, likely to experience day-to-day stressors due to racism, biased treatment, and flexible work environments. Black women, for instance, return to work on average sooner post-birth than all other mothers. They're more likely to lack personal professional breastfeeding support. Risk factors contribute to lower breastfeeding rates among Black women are clearly then visible. Next slide, please. So then that eliminating breastfeeding barriers becomes this complex, multidimensional phenomenon as well. That in order for us to adequately and effectively eliminate some of these barriers, that they have to be the solutions themselves need to be socially contextualized, and they must exist at all those levels that we just reviewed in the ecosystem. And the barriers uniquely for Black mothers, compounded by historical and racist institutional practice, have to be addressed effectively in order to prevent them from continuing to hinder breastfeeding behavior. The solutions have to be multidimensional. They have to be multi-level, multi-systemic, comprehensive, and seamless. And I can't stress enough, really, that mother's voice has to be the most significant driving force in all of it. And we'll hear from one of our panelists the significance of that. Next slide, please. So, it's really at this point that I think I can say I've kind of set the stage and painted the background for understanding what we're up against in terms of setting the foundational supports for providing breastfeeding support, so that there's circumstances that have to be in place. I can now move to, I want to introduce our panelists, our wonderful panelists who will bring you into a much better understanding of some of the specifics around providing this kind of support. Ms. Latasha Holly, our first speaker, is a representative from Black Mothers Breastfeeding Association. Just into the Ms. Holly contributes her background in counseling with her strong interest in Black maternal health and breastfeeding, and her role as a program associate for Black Mothers Breastfeeding Association, BMFA. Ms. Holly is a BMFA mom and was a regular Black Mothers Breastfeeding Club participant before joining the BMFA team. Ms. Holly joined BMFA staff in 2019, and she's played an integral role in coordinating and organizing events, such as the annual meeting of the Black Breastfeeding Caucus, the Basic Needs Giveaway in partnership with local Detroit agency and the Black Mothers Breastfeeding Club reunion. Ms. Holly has a bachelor's degree from Western Michigan University and a Master of Arts in Mental Health Counseling from Spring Arbor University. As well, she has several years of experience as a counselor and as a community advocate. Ms. Holly is also an active member with the Black Breastfeeding Caucus and Birth Detroit. She is the representative for BMFA as a kindred partner of Black Mamas Matter Alliance. Ms. Holly is a wife, a mother of 2 daughters, and she is thankful to have enjoyed a breastfeeding journey with both her children. So I think I'm going to introduce each speaker and allow them to speak, and then maybe introduce each individually just prior. Does that sound like that would work?
Just for the sake of time, I think we should let Latasha present, and then you can introduce the speaker right before the next presentation.
Okay, thank you.
Hello, thank you. I think everyone can hear me. Thank you, Dr. Johnson, for the introduction and providing really good context for what we'll be talking about today. Like you said, my name is Latasha Holly. I'm a program associate with Black Mothers Breastfeeding Association, and I'm just thankful that Kadada gave me the opportunity to represent BMFA today. As an aspiring maternal mental health counselor, this topic is important. So I just hope I can make some connections between how breastfeeding peer support can positively impact mothers' mental health. So what is Black Mothers Breastfeeding Association, BMFA? It was founded in 2007 by Kadada Green, Doris Jordan, and Debbie Clark out of a need to support Black families in reaching their breastfeeding goals. The mission of BMFA is to reduce racial inequities in breastfeeding support for Black families. BMFA provides direct service to families in Detroit, Highland Park, and in Hamtramck, Michigan. So why the focus on Black women? I feel like Dr. Johnson provided really good context in this, but much of the work BMFA does is around lowering the preterm birth and infant mortality rates, which are typically higher with Black women and families. And a lot of the services we offer seek to lower those rates. There's also lower breastfeeding rates with Black women. There's a lack of breastfeeding support in the home and the workplace. And then there are cultural and social messages that discourage breastfeeding, along with the added historical context of slavery and wet nursing. And these are just several barriers that Black women face while breastfeeding. There are others that impact mothers' breastfeeding success as well, but I just wanted to highlight these. So here are some statistics on Black mothers' breastfeeding rates. I couldn't find one specifically for Detroit where we are mostly focused, but these are from Michigan. And so the initiation rates for Black mothers is 72%, which is pretty good. But as you see, at 3 months' time, only 34% of that 72% are still breastfeeding. And I received these figures from the Michigan PRAMS, the Pregnancy Risk and Assessment Monitoring System. And so in the PRAMS, they were listing various reasons why they stopped breastfeeding, but one of the main reasons they listed that moms stopped breastfeeding was because they thought they weren't making enough milk. But it showed with the other information they gathered that only 1 in 5 babies weren't getting enough weight. So I just feel like that shows us a gap in this possible breastfeeding education and moms knowing how to tell if their baby is eating well and gaining enough weight. So here's a fact sheet that we created that just shows the value of breast milk. So why breast milk? Why is it so important? Because babies win. It reduces chances of sudden infant death syndrome, SIDS. It's critically important for premature infants. It is rich in nutrients and antibodies. It enhances brain development. It fights disease and infection, and it's easy to digest. Families also thrive. It's convenient. It satisfies the baby right away, keeps the family close and secure and warm and comforted. It helps mommy with postpartum weight loss, and it keeps mommy healthy too. And the price is right because it's free. So this slide, the next slide, I just wanted to highlight this article because it's such great news. In the article, it states that Mayor Duggan and Dr. Khaldun credited a community-wide effort among a wide group of government, private health care, and nonprofit organizations that have worked for years, in some cases decades, to improve the odds of survival for babies born in Detroit. And BEMFA is one of the organizations that's listed as ones that have helped to lower the infant mortality rate in Detroit. And so that rate, it says, according to Michigan Department of Health and Human Services, the Detroit infant mortality rate plunged from 16.7 deaths per 1,000 live births in 2018 to 11 per 1,000 births in 2019. So there's a 1/3 rate reduction. So I just feel like that was good to highlight that breastfeeding works and just supporting mothers, specifically Black mothers, been working in Detroit. So the next few slides will highlight some of the direct services that BEMFA provides to families. Black Mothers Breastfeeding Club, BMBFC, is a community-centered, mother-led breastfeeding group. Pregnant and breastfeeding mothers come together for fellowship, sisterhood, parenting, story sharing, and breastfeeding support. And since it launched in 2008, BMBFC has run without interruption and has supported more than 1,000 Detroit participants. And I actually connected with BEMFA through Breastfeeding Club and just felt it was a great experience and a great way of connecting. Solid breastfeeding education is given by our community-based doulas and certified lactation specialists, and there's just time for mothers and partners to share their experiences and give support to other mothers in club. So I want to also try to make connections between what peer support could do for maternal mental health. I got this fact sheet from the Maternal Mental Health Leadership Alliance, and I feel like it does a good job of highlighting how peer support, which happens at Breastfeeding Club, can improve mothers' mental health. There are several things on here, but I wanted to highlight a few. One being that peer support can be a part of several different things mothers do to take care of their health. Self-care, therapy or counseling, and medication along with peer support can just improve outlook. Also, support groups can provide a safe and not judgmental space. It decreases stigma and shame. And specifically in our case, as it relates to Black mothers breastfeeding, there's a lot of stigma around that, but having that support through community in club can decrease that. And the types of peer support are emotional, practical, providing information, and companionship. And so another aspect of BEMFA's direct service is care provided by our community-based doulas. We define community-based doulas as trained community birth workers who provide culturally appropriate, kindred-spirited, non-clinical, emotional, physical, and informational support before, during, and after birth. And this slide just kind of highlights several of the ways that our doulas support families with help with breastfeeding, providing guidance for moms with proper latching and maintaining supply, staying with families after birth for their first feeding and then second feeding. This is kind of modified during COVID when they weren't allowed in the hospitals, but they still are in great contact with families early on to make breastfeeding successful. Postpartum care with continuing with 10 home visits with moms and families after birth until early postpartum, and then continuous help with support with breastfeeding, newborn and infant development, like giving activities for families to do, and then encouraging moms to come to club to be in BFC to communicate with other mothers about breastfeeding. And I feel like the last way we support mothers directly is through our WIC breastfeeding liaison. Erica is our certified lactation specialist who provides breastfeeding education to mom. And she provides that through one-on-one sessions or group information sessions. And those topics include WIC program info, helping baby properly latch, how to get and use a breast pump and making adequate milk supply. I believe all of BIMPA's programs try to support the whole mother, providing care, making referrals, or whatever a family might need. And this lovely picture here is of Malika and her son. She is also a BIMPA mom and has participated in programs and is also a mommy ambassador now, which is kind of like the volunteer arm of BIMPA, and it helps advocate for other women. But I wanted to highlight some of Malika's story because she had some breastfeeding challenges in the beginning, but she was able to get breastfeeding solidly established, but she kind of noticed something. So I'll start with her quote. My research was centered around me and the act of breastfeeding. I didn't even realize the social or cultural piece until I got breastfeeding established, and I still felt very lonely. What's going on here? I need some other Black women to connect with. People in my family were pushing back for me breastfeeding in public. I went to this private Facebook group for Black women who are breastfeeding. Someone recommended Black Mothers Breastfeeding Association. I went to a breastfeeding club and y'all haven't been able to get rid of me yet. So I just like this story because it just shows how even though breastfeeding was successful, she felt a loss and needed community to connect with, and BIMPA was able to fill in. And I also wanted to, I feel like personal stories are helpful. So I want to share my experience with my daughter's pediatrician to shed some light on some of the ways that I feel like providers can either support or hinder a mother's breastfeeding goals. And so this is a picture of my daughter. She was around 1 here. We've been breastfeeding, and then around like 9 months, I would say, it just seemed like her weight a little bit is slowed down. And so our pediatrician was like, okay, this is a little concerning, not really sure what's going on here. She asked some questions about breastfeeding. And then I just feel like the energy shifted, and she was like, basically, I hear what you're saying, but this could be considered neglect. I would hate to have to call the authorities in and basically like CPS in and have to do something because I see this as being neglectful. She's not gaining enough weight. I don't really understand why. I think maybe something else might be wrong. So that was scary for me. It was like a wake-up call, but I was like, okay. I didn't want to use formula. We were already 9 months in, and she's like, well, it'd be easier for weight gain if you just gave her formula. Here are some cans, you can do that, and then, she'll start to gain weight. So I left just feeling very down and discouraged. I was not part of my personal breastfeeding goals to stop before 1 year. We were almost there. I didn't want to introduce formula at this late stage. It just didn't seem important, like it would do anything. And so I reached out to the community that I created through BIMPA. At the time, they were giving out subscription services to this site that did on-demand lactation services. So I used that subscription. I talked with a lactation consultant. She gave a lot of good tips, said I should start pumping, just doing different things to like increase milk supply. And then she was like, adding more complementary foods would help as well. So I did that. And also I feel like I was encouraged by other mothers, talking with them, hearing their experience to just continue breastfeeding, adding more food, just doing different things that might help boost her weight. But I just felt like not seen. I don't know. Providers come from a lot of different perspectives, but I feel like we had a good relationship. So the accusation that I was intentionally trying to hurt my daughter still hurts to me. But I really feel like making sure that you actually provide families with support if they want to succeed in breastfeeding is very, very key. So I'll move on to the next slide. I think these are a few ways that providers can provide support to Black mothers during breastfeeding. And one is just centering mothers' voices. This is what Dr. Johnson talked on earlier. We really have to hear what mothers want and listen to her goals and desires in the short time that you have available. Also considering her family life context, all the different responsibilities she has to her family and other work contexts that she might have. On that PRAM survey I looked at, the majority of mothers said they receive their breastfeeding information from their doctor, midwife, nurse, or baby's doctor. So they trust you. Mothers look to you for advice on making sure that you're providing solid information. And if you're not sure, just referring to a trained professional, which we will hear from some highly trained lactation specialists next. And so this is all that I want to share. This, my next slide is my resource slide. So a couple sites that I feel like help mothers in their maternal mental health. Postpartum Support International also has like a diagnostic where you can either call or get service if you're trying to see how medications interact with breastfeeding. So I just want to thank you for your time. Thank you for listening. That's it.
Thank you, Latasha. That was fabulous. I have the great pleasure of working with many of our panelists here today. In particular, Latasha and I worked with BENFA. I sat on the board of directors for BENFA for many years, and I'm still a kindred spirit. I think Latasha describes herself that way, kindred spirit. So thank you so much. And I'm going to move on quickly because time to our next presenter, Dr. Lisa Hammer. Dr. Lisa Hammer is a board certified pediatrician and lactation consultant. Dr. Hammer combines years of experience in pediatrics and lactation and postpartum support to provide comprehensive breastfeeding consultations. And she addresses the needs of both mothers and babies. Dr. Hammer is a fellow of the American Academy of Pediatrics and a member of the Postpartum Support International and the Academy of Breastfeeding Medicine. Dr. Hammer is currently the medical director at IHA Breastfeeding Medicine. Had the pleasure of getting some little bit of background noise. Can I ask all participants to please mute themselves? Oh, thank you. Had the pleasure of working with Dr. Hammer on a Breastfeeding Center of Excellence initiative. Without further ado, I want to welcome Dr. Hammer.
Hello, everyone. I will just fill in a little bit more to that great introduction from Angela. Thanks so much, both of our prior speakers for the background and information, which dovetails into a lot of my passions and my interests, which is trying to improve breastfeeding support and in general postpartum support for all families. Little bit about my background. I am a pediatrician, but I am also a certified lactation consultant, and I now run a specialized medical practice where I see mothers and babies exclusively, usually dealing with some type of breastfeeding challenge, and try to provide them, non-judgmental, evidence-based care that incorporates, all of these psychosocial contexts that have been brought up so far. It's challenging work. It's definitely passion-driven. My background prior to my current practice, which I've been in for 5 years, I was at University of Michigan. I was a pediatrician there. I was a medical director of a women's and children's health center. I started the outpatient breastfeeding program at U of M. I also had the wonderful opportunity to work with Maria Music around developing an integrated perinatal mental health program centered in a primary care office. That's what got me involved more into the Postpartum Support International network, and I have gotten certification in that as well. I know that there's been a lot of discussion so far about all the psychosocial contexts. I wanted to focus a little bit more in my brief talk today around some of the medical challenges that families may be facing. So I was going to focus a little bit on perinatal mood disorders because that does dovetail into the mission of the MC3 program, which is one of the sponsors here today. This is my contact info if anyone wants to reach me. That is my email. That is my office phone number. I'm very willing to take emails or phone calls from professionals seeking help in supporting their patients. Patients can also be referred to my office for visits. One of my primary professional goals has been to provide, to reduce barriers to lactation services for all families. And in that vein, I've worked very hard to make our services covered by insurance and reimbursed by insurance. So we do take most insurances. If IHA, if I'm able to do it within my network, we accept any insurance that I'm able to do through my network. We do accept most Medicaid plans as well. So mothers can come in and get on Medicaid, can come in and seek services through us, and would not have a cost share or a copay as long as my network allows me to accept their Medicaid. So I welcome referrals or questions from providers. So I want to talk again on perinatal mood disorders. The relationship between perinatal mood disorders and breastfeeding is quite a complex relationship. Women these days in childbearing age are very, very heavily influenced, as we know, by social media. The images out there on social media can have the ability to impact both positively and negatively, I think, our moms' experiences. Next slide. I pulled these images specifically because I want to highlight the fact that images do matter. And right now, I feel like there's a lot of very unrealistic images of breastfeeding that are portrayed to young women. These images don't reflect what my postpartum experience was like. And I don't think they reflect, the experience of, 99% of mothers out there who are actually breastfeeding. But again, these types of images are what's out there. Women shown very glamorized, women shown being sort of pampered, women shown very easily returning to the workplace. This woman has a private desk, a laptop, able to pump hands-free. I'm a working physician. I don't even have a private office to go and breastfeed or pump in. So the majority of our women are not going to face these realities. And I think it's important to note that, because I think when they see those images and then their experience doesn't reflect that, that can really negatively impact them. So I think it's important for us to portray more realistic images and understand the impact of what we portray. Next slide. The realities are more like this study revealed, which is a study looking at over 500 postpartum women who were interviewed sequentially during the first 60 days postpartum. And I found this statistic particularly telling. 92% of women expressed concerns about breastfeeding on postpartum day 3. Concerns included over 50% expressing difficulty getting the infant to latch and feed at the breast, over 50% reported pain, and over 40% reported concerns about milk quality. These breastfeeding concerns raised by parents were highly prevalent and significantly associated with increased risk of stopping breastfeeding and formula use. And why I think it's important to take a look at this is we have to realize on postpartum day 3, currently in the US, most women have already been discharged home from the hospital. And so they're home without much support. So if 92% of women are expressing concerns about breastfeeding on postpartum day 3, but yet our medical systems really haven't created an adequate support network to support those moms at that point. They do often go into their pediatric offices, usually a day or two after hospital discharge. Those visits are usually focused obviously on the baby. Moms may or may not feel comfortable asking the pediatrician concerns that they have about their breast or their body. And so I find that a lot of women at this point just really are falling through the cracks and not getting the help and the support they need. Next slide. I'm not going to belabor this. It was already brought up, obviously, by our prior speakers, but many mothers facing early return to work is another huge barrier. Next slide. So, I showed some of the idealized images that women are seeing, but their realities are often going to be quite different, with lack of support, lack of medical support, lack of support in the workplace, sometimes lack of support at home and in their families, and then still feeling the pressure though to succeed. This Time magazine article with the headlines, "Are you mom enough?" That's the implications of that are huge. And moms are trying to succeed at breastfeeding. They're not getting supported, and yet they're often feeling like it's their fault, when in reality it's not. It's often not their fault. It's really the fault of lack of both medical, societal, systemic support for these women. And that's what I see, in my opinion, needs to change. The more I did this work from wearing my pediatric hat, where I would see the babies and the moms come in, and I realized that, really where I wanted to shift my focus was on, nurturing and empowering parents. And that's where I think we fall short. As Angela pointed out, women and mothers, and all caregivers, fathers as well, really are the foundation of that baby's future. I can guide the parents, I can provide them information, I can provide them data, but ultimately, by empowering and nurturing that family unit, that's probably where I have the ability to have the most profound impact on this baby's future. So my work started to really shift more and more in the context of pediatrics, but more and more towards empowering and supporting new parents. And it's why I made some career shifts and have focused now exclusively on supporting mothers in the perinatal period, because I feel like that's where support is really lacking, and mothers really can be quite vulnerable, and some additional supports can really have a big impact on her trajectory as a mother and on the baby. Next slide. So again, this is echoing some of what's already said, but it's my way of saying every mother has her own journey, and every mother comes into her parenting role and her breastfeeding experience from a different place. And it's incredibly important for us to take that into account as we help support and counsel and guide new mothers. I won't go into all the details of this slide, but a lot of the psychosocial, systemic and societal issues have been brought up. Again, I come from addressing things a little bit more from a medical perspective. There's a lot of medical issues that affect women at this point in their lives. Their birth experience, sometimes birth trauma, sometimes, breastfeeding related complications, medical complications, all of these things can affect their breastfeeding journey. And so I focus a lot on that, but again, also putting it in the broader context of their whole psychosocial situation. Next slide. But today I'm going to focus a little bit more on the perinatal mental health impacts. Estimates are that as many as 1 in 7 new mothers will experience some type of postpartum mood disorder, depression or anxiety or others. That's a lot of women. And that's a lot of women that we're trying to support who may be struggling with some sort of a mood issue and could really benefit from some support. This is a good reference to have. Postpartum Support International. It's a wonderful organization. It is accessible to patients. They can be referred. There is a 1-800 number here. They do have a website. What they can do is help connect women with providers in their area. If you are a provider and are interested more in this topic, they do have a 2-day certification course where providers can get additional guidance and expertise in the area of perinatal mood disorders. So I would highly recommend looking into that if this is an interest of yours. Next slide. So what do we know about depression and breastfeeding? We know that depressed mothers are more likely to stop breastfeeding. Supporting a mom through her depression and treating it can really, hopefully, maybe positively impact her breastfeeding outcome. We also know that mothers who do not breastfeed are more likely to be depressed. So there does seem to be a give and take, a back and forth here. And we're going to dive into that a little bit more. Next slide. Here's some more data. There was a study done with over 6,000 women. It did find that exclusively breastfeeding mothers reported less depressive symptoms, improved well-being, and more sleep. So if we have a mother who's at risk of depression, maybe she comes into pregnancy also already with some depression history or has some risk factors for depression, supporting her, helping her, promoting exclusive breastfeeding could be a protective intervention for her. So this is very important, to note. Another piece of information that came out of this study is that both mixed feeding, so doing a combination of breastfeeding and formula feeding, as well as formula feeding, did not have as much of the protective benefit. And it was interesting that mixed feeding and formula feeding had similar statistical outcomes. So really a large part of the benefit is going to come from moms who are exclusively breastfeeding. And as we noted in some of the social context, a lot of moms, unfortunately, who are returning to work early and things like that are going to miss out on this benefit of exclusive breastfeeding. Some of this data came from some wonderful work by Kathleen Kendall Tackett. I highly, highly recommend her work if you're interested in this field. She has a wonderful book titled Depression in New Mothers. Great read for anybody who's working in the field, supporting mothers in any capacity, really, even the peer counselors or medical professionals, counselors, anyone like that. It does dive into this relationship of depression and breastfeeding and a lot of different support strategies. So highly recommend her work. Next slide. Again, this just sort of points out that, the bottom here showing a win-win. Ideally, if we can get these mothers breastfeeding, it can hopefully protect them against depression. If we can manage and effectively treat their depression, it can hopefully protect breastfeeding. So, we're working on both angles, supporting their breastfeeding and managing their depression, hopefully for a win-win outcome for mom and baby. Some of the reduction in depression we think may be related to the higher oxytocin levels. Oxytocin is released with breastfeeding. We know that it helps with relaxation, probably helps moms get back to sleep quicker. And that may be a big part of what's protective for mom's mood. When moms aren't breastfeeding and are bottle feeding instead or pumping at work, they may not be getting that same level of oxytocin, stress release. And so that may be part of what's where the protective effects of exclusive breastfeeding comes from. Next slide. So I mentioned, helping moms manage their depression. This is a very big issue. Maria Music really is an expert in this field. And if there's questions in the Q&A, maybe she can address some of that. I think there's a lot of, first of all, there's a lack of acknowledgement and diagnosis of perinatal mood disorders. The mother in the postpartum period, can sometimes get ignored or misdiagnosed. Terms like, oh, you just have the baby blues, or you're just an anxious new mom, where moms may really be suffering from a very significant postpartum depression or postpartum anxiety. So the first thing is recognition and diagnosis and understanding. We see more and more screening for perinatal mood disorders happening in OB clinics, happening in the hospitals, happening in even now pediatric clinics are screening moms for postpartum depression. So there's definitely raised awareness. The challenge is, if we identify a problem as a healthcare provider, then what do we do? And one is there continues to be a lack of resources for psychotherapy, support groups, et cetera. But if you're a provider, hopefully you can find out what's in your area, find a resource list, have a resource list of providers for those moms to refer them to. So that would be the first step. And then as healthcare providers, I think there's a barrier in terms of concern about using medications in breastfeeding women. As providers, our ultimate goal is to do no harm. And I think providers aren't educated and aren't taught enough about medications and breastfeeding. And there's a real lack of data and research out there. So even if they try to find the information, it's often lacking. And providers are nervous. They do not want to do harm to mom or baby. So I urge providers, if you're concerned or worried or not sure how to treat moms who may be needing help for depression or anxiety while they're breastfeeding, please don't undermine or discourage their breastfeeding experience. Instead, reach out and get help. The MC3 program is a great resource for providers who need help in this area. Again, any questions in the Q&A, Maria could probably address some of those, but healthcare providers can call the MC3 program and get advice and questions answered about what might be the most appropriate medication for that mother. I also included here another resource. It's called the Infant Risk Center. It's run by a PhD pharmacologist, Thomas Hale, who's really the leading national expert on medications during breastfeeding. And he created this hotline. It's staffed by nurses. And there's a 1-800 number. It's not 24 hours a day. It's more like 8 to 5, Monday through Friday, Texas time. But mothers and or providers can call this number and get advice on, safety of medications during breastfeeding. And so that's something that even if you're not a medical provider, it's a resource number you could have and, give to moms if they're struggling with this issue of trying to understand what's safe for them while breastfeeding. But it definitely is very possible to help support and even treat medically, if necessary, mothers' mental health issues while still supporting their breastfeeding journey. And in the slides I showed, exclusive breastfeeding can be protective against depression. So again, when we've got a healthy, thriving breastfeeding experience going on, we want to continue to support and promote that, because that can be protective for mom's overall mental health. Any further questions on medications and breastfeeding? Again, let's bring them up in the Q&A. Next slide. Here's an issue that I deal with a lot in my clinic, because again, women are coming to me with breastfeeding challenges that I'm trying to help them solve and protect their breastfeeding journey. Breastfeeding pain. So women who experience severe breastfeeding pain at 1 day, 2 days, and 2 weeks postpartum were twice as likely to be depressed at 2 months. So, and women who reported dissatisfaction with breastfeeding early on were 46% more likely to experience depression at 2 months. The good news with this slide is that breastfeeding support had a protective effect on mom's mental health. So if you have a mom who is, having pain with breastfeeding, you want to follow her lead. Obviously, she has the choice to discontinue that breastfeeding experience, which might be the right answer for her and for her mental health if the breastfeeding pain is, is detrimental to her. However, what I would hope is that these women could at least first get some support and some help to see if we could reduce the pain. If we can reduce her breastfeeding pain and continue her breastfeeding journey, that's the ultimate goal. A lot of times we can with some good lactation counseling, reverse mom's nipple pain. Moms might be having a nipple infection. Sometimes I have to treat that with an antibiotic, and that reverses their pain. It's very rare that I can't resolve the pain. Occasionally that can happen, and then we do have to address that. It's not okay to leave a mom in ongoing pain. Especially if it's affecting her mental health. So no one would support, continuing breastfeeding in an ongoing painful experience, but we would support, getting help and trying to resolve that pain. Because if we can resolve that for her, that's going to have the best long-term outcome. Next slide. Depression, breastfeeding, and sleep. So that's a bit of a complicated relationship. I think there's this, myth out there that, women who are breastfeeding, are up all night breastfeeding their babies. A very, very common thing I hear in my practice is that mothers who are experiencing depression will often come in and say they've been counseled to supplement the baby with formula overnight so they can get more sleep. Let somebody else feed the baby, let dad bottle feed overnight, you need to get some sleep. And so we're going to dive into whether that's the right thing to do. And it's a little bit complicated. So sleep disruption, we do know decreases depression. So again, I think providers who are making that recommendation aren't necessarily coming from, a bad place or bad intentions. They just don't quite understand the breastfeeding relationship and sleep. This is a study that looked at close to 3,000 women at 7 weeks postpartum, and disrupted sleep was a risk factor for depression. The interesting thing, though, is that it's not necessarily the factors that we thought might be disrupting their sleep. So what interrupted sleep more than exclusively breastfeeding was actually supplementing or mixed feeding. So women that were supplementing or formula feeding at night weren't necessarily getting better sleep. Other things that can affect sleep were depression, previous sleep problems, sometimes first-time mothers, younger infants, interestingly enough, male infants, which I don't understand that fully. But so exclusively breastfeeding was not the biggest predictor of sleep disruption. However, we do know that sleep disruption can worsen both depression and anxiety. And so women that are experiencing this may need some counseling for sleep, but there may be better ways to do that. Next slide. So exclusively, this is very interesting work as well. Exclusively breastfeeding mothers actually got 30 to 45 minutes more sleep than mixed or formula feeding moms, and this was at 3 months postpartum. Exclusively breastfeeding moms got more REM or higher quality sleep than mixed or formula feeding moms, a significant amount. And we know that more REM sleep actually reduces daytime fatigue. So again, the thought may be that the breastfeeding experience overnight is less disruptive. The oxytocin release, we think, probably helps mothers get back to sleep more quickly. Where a mother may be getting up, preparing a bottle, warming the bottle, those sorts of things. Then they have to get the baby back to sleep. They didn't get that oxytocin release. They may have more trouble falling asleep. So when we can support, a successful exclusive breastfeeding experience, that's going to be protective of both mom's sleep and her mental health. However, statistically, I think one of the real challenges we face is that with the statistics shown by, Angela, the number of women going back to work and going back to work early means that these women are not getting the opportunity to have this exclusive breastfeeding experience that is so protective of their mental health. So a lot of these moms are working, going back to work early, facing challenges of pumping, bottle feeding, moms working, day shifts, night shifts, all these sorts of things, and those, when moms are in those situations, sometimes we do have to step in and try to help moms figure out, the best way to navigate their sleep. Next slide. So should depressed mothers be encouraged to supplement? I'd say the answer depends. If breastfeeding is going well, we want to continue that exclusive breastfeeding experience. It protects mom's sleep. It can improve mom's mood, and empower that mother. And that's the main thing that my goal is in helping these moms. We want to empower these mothers. So telling her to supplement, that can undermine her sense of self-efficacy, undermine her importance as a mother. And we don't want that to happen unless it's really necessary. Okay. On the other hand, there are some situations where mothers may need some help in getting better sleep. So mothers who may be experiencing, mixed or formula feeding or experiencing breastfeeding problems, while also trying to deal with an anxiety or a depression situation. So there are mothers that can really be struggling in this area. And again, if she really is struggling with this area, sleep can make a big difference for her mental health. So, situations, for example, may be, there are some situations where maybe babies are dealing with medical issues, a NICU, a preemie baby, babies that are necessarily bottle feeding for medical reasons, et cetera. So some of these moms that, maybe the caregiver getting up, trying to pump and bottle feed a preemie, things like that. That's a lot to expect from a mom. And that is extremely disruptive of her sleep. So in those situations, we do need to get her support. We need to counsel family members to step in. Mom may need to get up and pump to provide milk for the baby, but another caregiver can do the bottle feeding or change the diaper or get the baby back to sleep. So moms who are in these non-exclusive breastfeeding situations, we do know that they suffer more sleep disruption, and they also suffer greater risks of depression, and they do need help improving their sleep. And And usually the answer to that, again, is finding other caregivers to step in and do a lot of the infant care while mothers can still do some pumping and provide the breast milk. They can get up and pump for 10 or 15 minutes, preserve their milk supply, go back to sleep while someone else does some of the caregiving and helps them get sleep. The problem with supplementing at night, telling moms to sleep a full night, is that will undermine not only their self-efficacy, but it will also undermine their milk supply. And we don't want to see that happen for mothers either. But there are lots of ways to protect a mom's milk supply while also getting others to help care for the baby overnight and still improving mom's sleep. Next slide. And this brings up another good point. I do talk to some moms sometimes who aren't sleeping well, but it has really nothing to do with breastfeeding or even with the baby care. It has more to do with their underlying, mental health situation. There are moms who baby is sleeping well and they can't sleep. So that's an important question to ask moms. Why are you up at night? Why are you not getting sleep? Is it because you're feeding the baby all night? Or is it not because you're feeding the baby, but the baby's fussy, being held, you're doing other parts of caregiving, which someone else could take over? Or is it that the baby's actually sleeping well, you're lying in bed unable to sleep because of some underlying anxiety or depression, or some other psychosocial stressor? And in that case, we need to help mom with those issues. It has nothing to do with the baby's feeding at all. And so, that's where this sort of false assumption or myth that mothers are tired just because they're up breastfeeding is not always true. Next slide. So postpartum depression has had a lot of increased awareness of late. And a lot of moms, like I said, are being screened for postpartum depression with Edinburgh screenings, et cetera. What's not getting as much attention, in my opinion, which I deal a lot in my practice, is postpartum anxiety. That can be very, very real for a lot of mothers. I think it often gets dismissed as typical new mom worries. Every mother's worried about the baby, things like that. But some moms can deal with pretty crippling anxiety. And I find that anxiety in breastfeeding is a very challenging a place for moms to be. They worry, is the baby eating enough? They worry, is the baby getting enough? They worry, are they doing the right thing? Should I be giving them formula? And so that constant worry, unfortunately, can sometimes undermine the breastfeeding and cause moms to switch to formula feeding because they can see the bottle, they can see what the baby's getting, and they feel like that's kind of safer in a sense, which isn't true. So what can we do to help moms in this situation? Next slide. I recommend, again, a lactation referral. If you're a provider and mom's expressing you concerns, I don't know if my baby's getting enough. I don't know if I should be breastfeeding. I don't know if I'm doing this right. I don't know how this is going. It's a perfect place for peer support or a lactation consultant. That type of support can go a very, very long way for an anxious mom. Having the baby weighed more frequently, having an assessment of the breastfeeding, having someone reassure her that the baby's gaining weight, the baby's getting enough, can really help preserve that breastfeeding experience and help reduce some of mom's anxiety. However, if they're getting that level of support and moms are still feeling very, very anxious, then she probably needs to be dealing with a provider who can actually help her address some of that anxiety. So we need to keep that in mind. Next slide. So breastfeeding and mood disorders, this is a very, very superficial touch on this topic. We could probably have a whole other webinar on this. But we got to remember that breastfeeding is not the same for all mothers. Breastfeeding is protective most of the time. However, for some mothers who may be experiencing issues or complications, it may not be best for them. We have to listen to mom. We have to listen to her needs. And again, mother's voice should drive this. Another thing that I just want to highlight again is that a lot of studies that come out compare formula feeding, full formula feeding against exclusive breastfeeding. And we have to remember that as much as we would like to promote exclusive breastfeeding and support all of our moms to achieve that, the realities of society right now is that the majority of our mothers are returning to work early. They're doing some type of mixed feeding, breastfeeding, pumping, some bottle feeding. That's challenging. And that adds a whole nother layer of stress and complexity to breastfeeding. And we need a lot more studies examining mixed feeding. and mothers who are experiencing challenges with that, pumping and return to work, drops in milk supply. We just need a lot more research looking into this so that we can get this data so that we can, adequately support mothers who are dealing with these challenges. And mothers deserve this support. Next slide. And so again, let's not forget about, our bottle feeding moms too, knowing that a lot of our moms are pumping and returning to work. That one of the early studies I noted was that exclusively breastfeeding is protective of mood disorders, but mothers who are potentially working, pumping, having to bottle feed, they may be at increased risk of mood disorders. And we need to acknowledge that. Women also may be feeling judged by family, friends, healthcare providers for their choices, and we don't want that. Women are bombarded by media images about breastfeeding, good and bad and ugly images, and that those images are very impactful. And unfortunately, social media has a way of taking off on us, and it's something we can't really control. But we have to remember that our mothers are being influenced by this. And try to support them and try to help give them a more realistic view of what to expect. And most of all, I don't want women to feel as if they're somehow failing as a mother or failing on this journey, when in reality, they're probably doing everything in their power to be the best possible mom they can be. And unfortunately, society is not really supporting them adequately. And so, again, I think the most important thing we can do in any of our roles is to focus on empowering these new mothers and reinforcing to them they're doing an amazing job and they're a great mother and a great parent, regardless of, how their individual journey ends up turning out. They know in their hearts, every mother I talk to, they want what's best for their baby. And they're trying their hardest to achieve that. And we as supports to these new mothers, by empowering them, that's probably where we can have the most impact on the future well-being of both the mother and those babies. So with that, I will turn it over to Tamika.
Yes, thank you. Thank you, Dr. Hammer. I'm going to, just to remind everyone, please place your questions into the chat box. We're getting lots of great information. There are also a lot of great questions coming into the, not the chat box, but the Q&A box. We're going to get to those in a minute. In the interest of time, we're going to forego a break, but I don't want to take time away from our next excellent, wonderful panelist and speaker. And I think some of the questions may be answered. I'm going to go ahead and introduce Ms. Tamika Dyer. Ms. Tamika Dyer is an international board certified lactation consultant with decades of women's and infant children clinic, baby-friendly hospital, and OB clinic community experience. Ms. Dyer is the founding member of the Southeast Michigan IBCLCs of Color, and she is owner of Crazy Milk Lady Lactation Support Services, LLC. She provides prenatal education and postpartum breastfeeding assistance through home visits in the Metro Detroit area. Ms. Dyer began her career in lactation as a breastfeeding peer counselor with several Metro Detroit WIC agencies and earned certifications as a lactation educator, community health worker, and a lactation specialist during EMU under the CDC and Prevention, Racial and Ethnic Approaches to Community Health, Healthy Asian American Project. So that's a mouthful, but Ms. Dyer acts as the lactation consultant for the Healthy Asian American Project, otherwise known as HAP, partnership with Wayne County Healthy Communities under the National Association of County and City Health Officials, NACHO, building Reach Community Breastfeeding Continuity of Care Project. In addition to her work with EMU, or Eastern Michigan University, and the Wayne County Healthy Communities and co-effective, Ms. Dyer is the wife and mother of 3, and she is an IBCLC LCL Continuing Education Content Reviewer for the Michigan Public Health Institute. Ms. Dyer chairs the Metro Detroit Wayne County Breastfeeding Coalition. She is a volunteer mentor with Sister Friends Detroit, and she's also administration for God's Liquid Gold Breastfeeding Support and Education Facebook page. Without further ado, I want to go ahead and welcome Ms. Dyer. Thank you.
Good morning. I'm mindful of the time, so I may talk a little bit quickly, but today I want to talk about going beyond the stats and the studies. The two previous speakers gave lots of information and lots of studies and research, but I want to look at the wisdom of breastfeeding supporters. So next slide, please. I do have research, however, to back up what I'm talking about. There's about 3 slides at the end of my presentation if you want to look at that later. My grandma is the wisest person I know. She will be 90 years young next month. And in her time on this planet, she has learned a lot and taught even more. She's an educated Black woman who fought for her education during a time when there were very few places like hers in the halls of academia. One of the greatest lessons she has imparted to me relates to the acquisition of wisdom versus knowledge. This version of the quote accredited to Socrates says it best: "I am the wisest man alive, for I know one thing, and that is that I know nothing." The number of degrees, years of study, and letters behind your name only mean that you have gained knowledge, not wisdom. And this is coming from someone who is quadruple certified in lactation. I am very, very proud of the letters behind my name. However, I know that those who operate in wisdom understand that they do not know everything. There will always be someone who knows more than you do, and life is a constant learning experience. In the wise words of my grandmother, an educated fool is still a fool. You don't know what you don't know, so be open to learning new things and different ways of looking at the world. Next slide. So, research and lived experience can coexist. Anecdata is very often the motivating foundation for research, and hypothesis is the genesis of scientific inquiry. We can't prove why the mammary glands of human females remain enlarged even without the pregnancy or a nursling, unlike other mammal females, but we can postulate. Knowing this, why do we find it so easy to dismiss anecdotal evidence gleaned from the lived experience of those who we serve? We know that correlation does not equal causation, but when the same thing keeps happening over and over again within the same situational context, that warrants a deeper look. So this photo was taken from a study regarding kangaroo care, immediate kangaroo care for very low birth weight infants. They found that these babies actually stabilized more quickly and were more likely to survive if they were given to their mothers immediately to start kangaroo care, rather than being stabilized in a traditional medical setting. We know that skin to skin regulates babies' breathing, body temperature, heart rate, blood sugar, lowers their cortisol levels, all of the things that are needed for a fragile baby to stabilize. Birth workers and lactation supporters around the world have known for many, many years that placing a baby skin to skin with mom immediately after birth and then wearing baby on a near constant basis made for happier, healthier moms and babies. They knew it was especially important for the survival of sick small babies to have that immediate and constant contact with their mother. But their wisdom was not respected, and a study had to be done to prove what they already knew. Why did we need a study to know that it's important for babies to be held by their mothers? Next slide. So today we're talking to healthcare providers about breastfeeding and why it's important. So why should you be concerned about breastfeeding? Well, have you ever directed a nursing mother to pump and dump? Told a mother she had to supplement with formula? Informed a mother she couldn't breastfeed because of her medical condition or medications? Or encouraged a mother to night wean to get more sleep, as Dr. Hammer just spoke on? Do you have any idea how difficult it can be to get a measurable amount of milk in a pumping session, and how disheartening it is to have to pour that hard work down the drain? That would definitely boost depressive or anxiety symptoms. Do you know how much formula costs or how to prepare it properly at 3 a.m. while half asleep with a screaming, hungry baby? Are you aware of how devastating it can be to hear that something you want to do, that you've been told over and over again is the best and right thing for your baby, you cannot do? Do you know which medical conditions or medications are actually contraindicated for breastfeeding? There are very few illnesses or meds that preclude breastfeeding or the provision of mother's milk. Are you cognizant that night weaning can impact supply severely enough to cause total weaning, even if that's not what the mother wants? Plus, breast sleeping mothers, taken from Dr. James McKenna's research on breastfeeding during sleep, the two do go together. It's a little controversial because it involves co-sleeping, which is something that a lot of providers are not comfortable with. But breast sleeping mothers actually get more sleep than their formula feeding counterparts, as Dr. Hammer pointed out, and studies show that babies still wake at night, even if they don't want to eat. So if you've stopped breastfeeding and baby wakes up, now you have to get out of bed, fix a bottle, or if that's not what they want, you're still going to miss out on sleep. Also, mixed feeding mothers who choose to nurse at night and formula feed during the day, in my experience, actually are able to get a lot more sleep than those who do mixed feeding throughout the day. A friend shared some mother wit with me a few days after my first was born that totally reframed the way that I looked at having a newborn. When I complained of not being able to put her down or couldn't understand why she would not sleep unless she was up against me, my friend told me that my baby girl did not yet realize that she was no longer a part of me, and it would take her a little while to figure it out. I still use that nugget of wisdom when I'm working with clients to this day when discussing expectations of sleep and normal newborn sleep patterns. Next slide. So there are some things to contemplate. How do you feel about breastfeeding? Do you have a negative breastfeeding experience in your family or in your own personal experience? How does your personal bias affect the way that you practice? There are many things that we've been taught in our capitalist culture that do not mesh with the reality of pregnancy, childbirth, and the postpartum period. We believe that we have a more advanced culture, but the things that capitalism holds dear, like self-sufficiency and independence, do not translate to success in the postpartum period. Because biologically, mothers and their newborns are hardwired to coexist as a dyad, as one entity, and biology does not care about culture. The Gallup study that Dr. Angela spoke about in her introduction is one that I came across during research for a presentation that I did on lactation and loss in 2019. And I shared it with the team while we were getting ready to work on this webinar. And it was fascinating to me to think that bottle feeding mimics infant loss. Dr. Gallup found that because of the way that the hormones are set up after birth and the way that mothers and babies interact with each other, that historically, if lactation did not occur after delivery, it was because the baby did not survive. So because that is how our bodies are set up to work after delivery, if that does not happen, if there's an interruption for some reason, because mama has to go back to work at 2 weeks, which I saw often when I worked in the WIC clinic, or she's ill and has to stay in the hospital, or baby's in the NICU, those things can set up the biology that occurs with a loss, which of course negatively impacts mental health. Lactation is a biological process, but breastfeeding is a cultural phenomenon. And the fact that our culture is unsupportive of this process often creates very real emotional and mental distress that can cause or worsen some perinatal mood disorders. You can see that my private practice is called Crazy Milk Lady Lactation Support Services, and that was actually born of my experience with my first child. I suffered from postpartum depression. Actually, it started during pregnancy, but I was not aware that it was an issue until my sister pointed out to me that I never held the baby unless I was feeding her. So I can just imagine how disconnected I would have been from her if I had chosen to formula feed, if I had listened to the physician who told me that she wasn't gaining enough weight, though she actually was. They were using a chart for formula-fed babies and not breastfed babies. But I felt crazy. I felt like something was not right, but I couldn't actually put my finger on it. And I was afraid to talk to my doctor about it because, as Latasha pointed out, often when we discuss mental health concerns or not feeling right, especially as a Black woman, we are far more likely to get a social work referral or have CPS called on us or risk losing our children. So that wasn't something I felt comfortable talking to my provider about. Luckily, I did have friends and family members who were paying attention. My mother is a psych nurse. She's been an RN for over 20 years. That recognized the issues, and I was able to get help. But during that time, I just felt like my baby didn't want me unless she wanted to eat. And I was just the milk lady. And I felt crazy. Crazy milk lady was born. Next slide, please. So know that your opinion matters. So be sure that it's evidence-based and not based on your feeling. Breastfeeding is not a lifestyle choice. It is a public health issue. And patients listen to what you say and what you don't say. The reality of being primarily responsible or solely responsible, as is the case with many of the women that I serve, for a brand new human being is a very heavy weight to carry, and one that most women in our society are woefully unprepared for, because we don't talk about the hard parts or the fact that the hard parts are actually normal. And in new mental health issues or a pre-existing condition that is exacerbated by the biological changes of pregnancy, unsupportive family members, uneducated healthcare providers, and the soup of hormones that's flooding your body and your brain, along with the extreme sleep deprivation that comes with having a newborn, regardless of how you're feeding them. And we set mothers up for failure. Many of the mental health troubles that women experience here in America or in the West are virtually unknown in traditional cultures where mothers are actually supported and surrounded with family and caregivers during the postpartum period. There is almost no SIDS, even in cultures with family beds that practice co-sleeping from day one or breast sleeping. They even start in the hospital. And that's because they treat the dyad as a singular entity that should be kept together and treated as one for those first few weeks or months. As an international board certified lactation consultant, I must pay attention to the ways that other countries and cultures approach breastfeeding and the early postpartum period. Next slide. There's been some talk about IBCLC. I'm going to give you a little bit more information because a lot of people have absolutely no idea what those letters mean. Lactation consultant, or LC, has clinical expertise in the management of breastfeeding difficulties. We're certified by the International Board of Lactation Consultant Examiners. We work inpatient and outpatient, providing evidence-based care and advocating for breastfeeding families. It is the highest level in lactation. I am quadruple certified in lactation, but IBCLC is the gold standard. It is a standalone credential because the average physician receives a few hours of lactation education during the entirety of their schooling. My cousin is a hospitalist in Hawaii, and I remember she and I were talking, and she was telling me that she learned more about breastfeeding sitting with me at the family reunion than she did in all her years of schooling. And that was really eye-opening for me. And it made a lot of sense with the way that some physicians interact with lactation consultants. In comparison to the few hours of schooling that doctors get, in order to sit for the exam to become an IBCLC, not become one, just to take the test, you need 300 to 1,000 clinical hours of lactation-specific hands-on work with clients, 95 hours of lactation-specific education, with 5 hours of that being in communication. As a WIC breastfeeding peer counselor, I got counseling education constantly in the 5 years that I was there. 14 health science courses, including nutrition, sociology, psychology, child development, research and statistics, anatomy and physiology, along with ethics, universal safety precautions, and basic life support. All of this education must be completed no more than 5 years prior to applying for the exam. We're required to renew our basic life support training and earn 75 continuing education hours and 250 consulting hours, or retake the exam in order to recertify every 5 years. We are the experts. I don't just have the knowledge of my training, but also the wisdom of my experience as a mom who has over 45 months of breastfeeding experience under my belt, as well as working with thousands of women over the last 2 decades. I know that most women, up to 80%, experience the baby blues, and up to 20% have more serious, longer lasting disruption of their mental health. I also know that a client who scores a 0 on the Edinburgh postpartum scale is probably lying to me. I can look at a client's intake and ascertain what their issue might be, but I also talk to them and listen so that they feel comfortable telling me the things that they do not tell their physician. I'm in several professional lactation groups on social media, and someone came talking about a client who had been prescribed trazodone for their depression, but they bed share. Trazodone is very sedative. It's an extreme sedative. And someone in the group commented that their prescriber should tell them not to bed share. And I responded that their prescriber may not know that they do that, because that's not something that they often share with their physicians because of the judgment that is attached to that. They share things with us that they don't share with their providers, whether due to the time constraints, because doctors only get 15 to 20 minutes to discuss with their clients, whereas an intake or a consult with me is about 2 hours, or the fear that we talked about earlier of being reported to CPS or having a social work referral or being told that they're being neglectful or a bad parent. We have the time to spend, and they trust us not to report them. When you encounter an issue that is outside your scope of practice or beyond the knowledge that you have, you refer to a specialist. If a client presents with strange chest pains, you'll send them to a cardiologist. If a client has a rash with no discernible source, you send them to an allergist. If a patient complains of horrible headaches that is far worse than any type of migraine you've ever seen, you send them to a neurologist. Lactation should be no different. I utilize my network to ensure that my clients receive the best care possible. And all we ask is that you do the same. Next slide. Since there's often a lack of experience and information for the clinical management of breastfeeding dyads, I want to talk about ABM, which Dr. Hammer is a member of. And this is Doctors Helping Doctors. The Academy of Breastfeeding Medicine is a group of doctors that is worldwide, and they are dedicated to protect, promote, and support breastfeeding and human lactation by developing protocols to help you with many of the common concerns that we see in breastfeeding dyads. They tell you how to handle hypoglycemia, nipple pain, slow weight gain, all kinds of things. Next slide. Since our focus today is on mental health in the postpartum period, and confusion about the safety of medications during breastfeeding is often at the heart of misinformation that the patients receive, I want to give you some more resources regarding breast milk and medication. eLactancia is a really good app as well that you can download to your phone. LactMed also, it's one that I keep on my phone when I'm doing consults and I'm in the field. I can just look at my phone and look up a medication and give mom the information that's listed there. Medications in Mother's Milk is the Lactation Consultant's Bible from Dr. Hale. It comes out every other year, and it lists lactation, the impact on lactation from L1 to L4, with L1 being safe, no issues, and I'm sorry, L5, and L5 being absolutely contraindicated for breastfeeding. Next slide. I also want to mention that the PDR is not an appropriate reference tool. It is a legal document. It is not a way to get education regarding whether or not a medication is safe. It almost always says to cease breastfeeding or to, not take a medication while breastfeeding. So I want to talk about epistemic testimonial injustice. Miranda Fricker identifies testimonial injustice as a case where a hearer assigns lower credibility to a speaker due to identity prejudice. She considers it a form of epistemic injustice since it wrongs the speaker in her capacity as a knower. So check your bias. Don't disregard what a lactation consultant is telling you because your identity prejudice does not include them as a healthcare provider. Recognize that your patient knows more about her body and her baby than you do. If a patient says that breastfeeding is protective of her mental health and makes her feel better, listen to her. Ensure referral to community supports to assist her in meeting her goals. Discuss medication options that are compatible with breastfeeding, or refer her to a lactation consultant to create a feeding or pumping plan if the meds that she needs will require closer monitoring or some supplementation. And conversely, if a patient says breastfeeding is too much and she wants to stop, listen to her. Because I can tell you that as a mom who has breastfed, I would have been a horrible lactation consultant after my first baby because I had a wonderful breastfeeding experience. We really didn't have any issues other than the fact that I was horribly depressed for most of her first year. But breastfeeding was actually going well, and it was the one thing that kept me going. And I couldn't understand why everybody didn't breastfeed until I had my son. And we had every issue you could think of. That gives me a lot more empathy when I'm working with my clients. So if a mom is having so many issues that she just cannot do it, refer her to a lactation consultant that can assist with weaning and milk cessation, transition the baby to a bottle or a cup, and educate her on safe preparation of artificial breast milk substitutes and introduction to solids if developmentally appropriate. IBCLCs do far more than just latch babies to breast. We are highly skilled and qualified members of the healthcare team that are here to help women meet their lactation goals, whatever that may look like. So please include us in your work with your patients. Thank you very much.
Thank you, Tamika. And I really want to now say many, many thanks to all of our panelists for the illustrious information, expertise that you've shared. I'm learning more every day. So we want to, at this point, we want to thank everyone for participating, including our parents. We are at time. And it's unfortunately, I have to say that, we want to honor your time, and we won't have opportunity for taking questions and answers. But what we do plan to do, we're certainly going to honor all of the wealth of questions and concerns that have been voiced in the Q&A box. We will be curating all the questions in the chat and the QA. We will email responses to our panelists because we are currently at time. My apologies. This just really hammers and reinforces the message today. I think we've all learned just how important it is that we all come together as a collective team, and that we reinforce and we collaboratively work together as a seamless entity to support and to nurture and cultivate, as Dr. Hammer and Tamika and Latasha has so adequately mentioned, and that this webinar is really one way that we can come together. We can bring many groups together to start this ongoing conversation and dialogue about ways that we can support mothers. So we want to thank all of our panelists, and many thanks to Zero Thrive and MC3 Perinatal Expansion Team. Contact information is there. I'll turn it over to Dr. Musick for closing remarks.
Well, I just want to join the accolades to all the speakers. I think that, everybody was stellar and bringing their perspective and their rich wisdom and experience into this discussion. And I think that for me, the most important piece that we take away from today, that it's the beginning of a conversation of breaking down the silos, breaking down maybe kind of perspectives that have been too much polarized and you know, kind of discussed in individual groups, and are not cross-fertilizing, not cross-shared, and are not leading to a richer, more comprehensive, holistic discussion that really, I love the way how it was stated. It's the voices of the mothers, the families, and the experts coming together and being a foundation for more holistic, nurturing, and relationship-based care that we need to help, support, and create. And I really love, Angela, also that you brought the context in the beginning, because there are so many forces, historical, cultural, societal, capitalistic. I don't have to tell you, I'm from Austria, 3 years paid maternity leave, very different structures that are supporting the systems of care. And so if we really want to make a change and change policy in this country, in our state of Michigan, we need to work together as a unified force. We cannot work against each other. That's where I would like bring us together and say, I'm really thrilled that this is the beginning of a rich conversation. And I want to thank you. And I hope this is the first of many collaborative spaces and brave discussions that we will have around this topic. So thank you very much, everyone. And sorry, we are 2 minutes over time. We will get you the responses back from the panelists via email, but I want to thank everyone for being here today. So my appreciation, we appreciate you. Thank you.